Welcome everybody to the Iowa Autism Symposium. We're so glad you came bright and early this morning. Some traveled through rain if you're on the west side of the state. So again, thank you for coming. My name is Peggy Swales. I work with the Division of Child and Community Health at the University of Iowa, and I am a program manager for the Iowa Regional Autism Assistance Program. We'll be referring to that as RAP throughout the day. So when you hear that acronym, RAP is for that program. So I want to share just a little bit of information about how the symposium came to be. The University of Iowa received a federal grant 2 years ago, started September 1st, and we're just ending that project period August 31st. And the funder was the Health and Resources Services Administration. We refer to that as HRSA. And so we always have to disclose that, as well as saying that any content provided today should not be construed to be the position of the federal government. So with that, so in addition to money, to plan today's event, it also takes people. And so we've listed up here our planning committee members, and it's taken a year. We started this process about a year ago, planning, and so you can see we have a very diverse group. We have educators, we have family members, we have service providers. So again, we appreciate all their support, and if several of them are here today, most of them are, if you wouldn't mind standing up for just a second so we could recognize you, because again, we appreciate all you've done. Thank you. Great, thank you. And then a special shout out to Sabrina. Sabrina Schultz Mcclain. She has led the symposium committee member since earlier this year, and she can't be here today because she had a healthy baby boy early Sunday morning, so she's snuggling with him. Okay, and so then housekeeping. And I won't talk too long because I know we're all excited to hear Dr. Nate Noble. I just want to point out a couple of areas. One are the restrooms. That's always important, right? They are right when you walked in at registration. You can see the restrooms there. Also, everybody should have received a blue folder when they registered. The right side contains the presentations throughout the day. We also have an evaluation form that we'd appreciate you filling out at the end as well. Nurses, in the room you'll have an additional evaluation form to complete for your CEUs, so just wanted to let you know that as well. And then there was an error, I apologize, in the brochure for CEUs for the nurses. It's 7.2 CEUs today. And one more thing about the CEUs. If you don't mind seeing Kathy Francis, here she is. She's handling the CEUs and returning them into the College of Nursing at the university. She has these forms as well that need to be completed. And there is, these should be in your folders. Is that right? No, okay. So you can see Kathy for those. If you do have a folder, we do have the program number. If you want to write that in, I'll read that off. 16-201-93. So again, that's 16-201-93. Okay, and another area is today's session is being recorded. We're recording all of the presenters, and we will have those uploaded probably within the next 6 to 8 weeks is what we're hoping. There'll be some editing, and then they'll be available to you on a website. We have all of your emails. You're registered electronically, and so we're going to send you an email once that's available online. And so educators, parents, families, service providers can all share that information. Okay. All right, and then lastly, we also have an electronic resource goodie bag. We're referring to that, and that also will be coming out in the next few weeks. That will contain all the presentations in PDF, as well as brochures from different service providers across the state. Just want to blast that information out to you, so I'll be watching for that. Okay. All right, so without further ado, I want to introduce our keynote speaker, Dr. Nate Noble. Okay. Thank you. Thank you. Dr. Noble is the medical director at the Anna Blank Developmental Center here in Des Moines. He specializes in the care for children with special health care needs. Dr. Noble completed his pediatric residency training at Blank Children's Hospital. His fellowships were at the University of Iowa in both developmental, behavioral pediatrics, and clinical genetics. He has conducted research on genetic disorders, focusing on genotype, phenotype conditions, and care coordination. So please join me in welcoming Dr. Noble.
All right, good morning, everyone, and thank you. Thanks for having me. As Peggy said, my name is Nate Noble. I'm the medical director of the Anna Blank Developmental Center, which is connected to Blank Children's Hospital. We've been providing services for children with special health care needs in Central Iowa since 2012. And so, in that, I always joke, like I left the University of Iowa 5 years ago, and since then, a number of things have happened. The first of which, I went almost completely gray. Like, people are like, how's it going in Polk County? I'm like, well, how do you think it's going? Take a look. And I also have knee pain and back pain, which is also new. I have a beautiful bride and 4 kids, and so certainly there's reasons to be gray there as well. But with that, let's get started. I don't have anything to disclose, but I think it's important that you know when we get started that I'm learning is often the worst thing you could do in a presentation is to start out with an apology. It's absolutely the worst thing you could ever do, right? But I want to just be honest with you in that I don't have anything to disclose, but I truly do care for these kids, okay? And there's some people maybe in this room that I've seen or I've met and I've talked to you and your families, and I want you to know that what I told you, I meant, okay? And when I speak at places like this, sometimes the passion comes up and I get a little emotional. So if that's not you, this could be the cry area right here. It's like, you get the splash zone. So just watch out. And I'm not sorry for it. And the truth of the matter is, the thing about working in the field of developmental disabilities is that I've never come across so many people who would literally go to work for nothing. Like, think of the people that you work with. Think of the reasons that brought you to the field that you're in. Some of you who are working in the field, some of you have families in the field who've been directly affected. I have never in my life worked with a more captivated group of people who would literally work for free for what they do. So, think of the possibilities. And truth be told, I am absolutely, as a developmental pediatrician, I am lucky to get paid. Okay, now, references are available upon request. That's as academic as I can get. Okay, so I've never been a keynote speaker before. Truth be told, I probably will never be one again. But I asked some of my friends who were keynote speakers, because this is a great idea. Let's email them, let's call them and see, what do you guys think? This was classic. This is what one of my friends said to me, who had been a keynote speaker. He said, listen, you have your perspective and your points to make those. It's a balance between a lounge act, information people can use, and a time for you to pontificate about what you think needs to happen. Take advantage of that, and then he ends it with hashtag say what you want to say, which I just thought was just that's it. I'm doing it. So that's the information I pulled from to put this together. Here are the objectives for our time together. And my intent today is to talk to you about what I see, what I very firmly believe are the 5 pillars of care for children with autism spectrum disorders. Now, there's different ways to look at this. This isn't something you're going to read in a book. It's not something I was taught in fellowship. But from my perspective in Central Iowa, partnering, locking arms with local care providers, trying to figure out how to coordinate care in Leon, how to care about the kid in Spencer, how to worry about what's happening in Council Bluffs, what to do when there's no developmental pediatric services in Sioux Falls anymore. These are the kinds of things that have bubbled down to me that are truths. So this is me pontificating about the 5 things that every kid in Iowa needs. Every child with special health care needs, including children with an autism spectrum disorder. But there's problems. There's big problems. I'd also like to spend some time talking to you about the paradoxes that exist within each of these pillars. Not so that we can all be like, oh, this doesn't really work very well, huh? But more so that we can understand that there's a tension that exists, and if we don't understand it, how can we possibly begin to change a system we don't understand? And then lastly, I want to spend just a very brief amount of time talking with you about what I would suggest is the envisioned future of this state. It's more philosophical. I'm not here to give you, I'm not here to script it out. I'm not here to tell people what to do or to think about, but I just want to give you some ideas about if I were going to be hit by a bus tomorrow, this is what I want you to know about today. Okay, so before we get started, I want to talk just briefly about the clinic visit. Because oftentimes what I run into is that people, my wait list is not unlike a lot of people's, it's several months. And people are waiting, and what they want to do is they want to find out what's happening. They're waiting for the assessment. Dr. Noble, what's going on? Dr. Noble, what's your diagnosis? Hey, you saw Dr. Noble, what did he say about the diagnosis? So much of our time is spent, and so much emphasis is placed on assessment, but the truth of the matter is, you and I both know, most families already know. Now, maybe they haven't understood necessarily how to operationalize the DSM-5, maybe they haven't really put all the pieces together using an ADOS or doing certain presses within the clinic or measuring joint attention. And I don't mean to say that, so maybe they don't know that autism was the concern, but truth be told, most people know that there's a problem. Right? No one comes into my clinic is totally shocked. They're in a developmental genetics clinic with a 6-month wait list. They're not like, really? So there's some things we need to work on? Like, just nobody says that. But here's what I want you to understand about this. When I see kids, my intention, when I think about what's most important, I would submit to you that it's not the assessment. It's not the assessment. It's not the diagnosis. Now, is a diagnosis necessary? Yes. It's a key. A key to what? Unlock a door. But is it a door you're going to walk through? Is it a door you're going to walk through? I saw Dr. Noble. My child's got a lot of neat strengths. He's got some struggles. He lives in the middle of nowhere, Iowa. And Dr. Noble thought, well, he's got some emerging skills. He had handling services. We know about receptive language. He used something like a social communication disorder. He used some kind of other thing. He didn't use the term he didn't use the diagnosis autism. But what I want you to understand is when I make an assessment, when we come to a diagnosis, I come to that diagnosis with a family. I firmly believe that families have a say. They get to decide along with me. I work for you. I work for them. I ask them, here's the different ways that this can play out. Here's where you live. Here's the insurance that you have. Here's how many cars you own. Here's how you live in a 1-bedroom apartment. Here's how you're now divorced. There's all these narratives that have to be played to understand how best to serve a family. A diagnosis or an assessment is only as good as the door you're going to walk through. If you're not walking through it, then I would submit to you that maybe the assessment is not the most important thing. I often tell families, listen to me, when you got up this morning, you got Johnny ready to come to see me, you fed him and you bathed him and you got him dressed. Some families bathe and dress their kids. Other kids, they just kind of look like my kids. And I was like, yep, I know what your day was like. And I say, listen, when they get up this morning, your child had a name. It was a great name. It was a beautiful name. It was John. So listen, please don't come and think that if we use a descriptive diagnosis like autism, that in some way, shape, or form replaces the name of the child. Because I know that you know this. I know all of you know this, but you also know people who do that, right? Everything is an apology. This is blah, 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 but he's got blah, 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 so that's why he's blah, blah, blah. And I always tell families, listen, you never apologize for your child. Never. The problem is not your child. The problem is everybody else. Assessment maybe isn't the most important thing. I already know what the diagnosis is. The diagnosis is awesome. That's the diagnosis. Is it billable? Unfortunately not. But is it accurate? Yes. Okay, but listen, what I want you to understand today as we talk is not the assessment. What we wait 6 months to find out, what we wait on bated breath to see what maybe the Area Education Agency says or Des Moines Public says or the psychologist says, is not the assessment, it's the plan. What I love to tell families is, okay, here's the assessment. Here's the diagnosis. Okay, we're going to talk about that. We're going to sit in that. We're going to own that. We're going to be in this moment. But when that's done, we're moving to what the most important thing is, and that's when we're going to talk about what are we going to do about it. And that's what I want you to understand about this talk today, is that what I care most is what we're going to do. But there's a few things here that are important. The first thing is that before you can, once we talk about an assessment, before we can really get into plan, before I can really help a family understand, these are the 5 things that must happen in the life of this child. These are the 5 things that must occur. We absolutely have to conduct a surgical procedure. I'm a developmental pediatrician, so I don't have a lot of procedures. But the only procedure that I conduct in my clinic with exacting surgical precision is the removal of needless, senseless, worthless guilt. And I will tell you, people come in and they've got it on their shoulders, right? They're slumped over. They come in and they sit down, and so many folks will keep it together. And they'll keep it together like they don't think I do this all day long. And at some point in the evaluation, I lean across, once we've talked about our assessment, and I begin to excise that guilt by saying, listen to me, there is nothing you could have done to cause or prevent this problem in your child. The only thing you're guilty of is being a good parent. And usually people will nod, and this is what they do. And then I wait, and I'll pretend to type on the computer. And I'll say, do you understand me? Look at me, do you understand me? There is nothing you could have done to cause or prevent this problem. You are not being punished. This child is a gift and a blessing. But do you understand? And then all the time, bam. I mean, I've got boxes of Kleenexes in my office. Before we talk about a plan, we got to excise guilt. When you care for families, listen to me, residents struggle with this. They think, well, what's the genetic evaluation, Dr. Noble? Should we do an imaging study? What, blah, blah, blah. And then once we leave an evaluation, and I sit down with the resident after we've conducted our time, we've finished our time together with families, and we do this kind of surgical procedure, I ask the residents, what do you think was most valuable to that family? Do you think it was me giving an assessment that they already knew? Or telling them about services that they may or may not be able to gain access to? Or do you think it was the time when the developmental expert leaned across the table and told mom, she's a good mom. You are a good mom. You're a good dad. You're doing a good thing here, right? It costs us nothing to encourage our families. It costs me nothing to invest in that. And so if you care for people, or if you're a parent or a family member in this room today, I just hope my intent today is that you would be blessed by that and know that that's true. So the first thing is we got to cut off guilt. Before we get to the pillars, which that will be the next slides, the other thing we do is before I can convince you of the 5 big things you have to do with this child to help them get to that next place in their life, I have to show you the future. I literally have to show you the future. And it helps me with this analogy because it's the Olympics this summer. It's the Olympics, Olympic time. When I say to the families, I say, listen, I've got great news for you, Mom, Dad. This is the Olympics. It's coming up, and both of you are going to win Olympic gold medals in the marathon. Right away, just bam. And I say, but listen, okay, if you're me, you can't run a block, okay? But let's just say that you believed me. Let's say you believe me. You're like, you know what? Maybe he's right. He's kind of strange, a little bit weird looking. But listen, he seems like he knows what he's talking about, okay? So you start to believe me. You leave my clinic, and whether or not you want to admit it, if you truly believe about what I've told you about your future, you will behave differently. It may not be all at once. Not saying you're going to go out and run 26.2 tomorrow, but you'll take the stairs. You'll change your diet. You'll buy different shoes. You'll start to think about yourself differently. When I see families in the clinic, I say to them, you listen to me. Listen to me. Your child, I absolutely believe, is going to learn to meaningfully communicate soon. Whether or not it's weeks, months, years, but they will meaningfully communicate. They will go to school. And they will go to school and they will be awesome at school. They're going to do fantastic. People are going to love them at school. They are going to go through school and do great. They're going to need services. They'll need some prompts and supports. But they are going to graduate high school and they're going to move out of your house because they're sick of living with you. Right? And you know what they're going to do? Whatever they want. They want to get a job, they get a job. They want to go to college, they go to college. And people say, well, how do you know that for sure? And I say, listen to me. Prove me wrong. Prove me wrong. I tell families, listen, I will bet you my medical license that and this child is 18 years old, I'm right. I will bet. If I'm wrong, you come back, you can have this clinic, you can have these degrees, because I'm done. What part in the story do you want to play? You want to be the doom and gloom? Well, there's no joint attention, there's not a lot of functional communication strategies, you live in Leon, so I go, wah, wah, wah. Or you can come in and give these people the most powerful medicine there is, and that's hope. And people say, oh, but no, but you can't give people false hope. And then I say, when has hope ever failed? When has hope ever failed a family? Answer me that question. You are more than welcome to sit in my seat, and I will take the day off. So, before we tell you about the pillars, we got to cut away the guilt, and I got to show you the future. So let's talk about it. The 5 pillars of care, as I see it, and I've updated these slides. I'm realizing that I've uploaded the old versions, but that's okay. We'll get through it. The 5 pillars of care, as I see it, are like this. The first of which is early intervention, area education agency services, Des Moines Public Services. These are free services. They're provided at no cost to the family. From 0 to 3, they come into the home. They're beautiful. They're crisp. They're just fantastic services. The next pillar is private therapies and services. So PT, OT, speech. Next is Medicaid. Children with special health care needs absolutely have to have access to Medicaid. Okay? I don't care which of the MCO Medicaid versions it is. It doesn't really matter to me. I know there's nuances, but some version of Medicaid insurance. Individuals must have access to, individuals with autism, ideally access to applied behavioral analysis, or ABA. And then lastly, children need to have a medical evaluation. I'm going to say that again. Children need to have a medical evaluation because autism is a feature of something else. Nobody takes a baby to the emergency room and the emergency room doctor says, you know what, don't worry about it, it's just a fever, you're fine. If you're gonna, okay, so fever is a symptom. What is the process happening? No one takes a newborn baby home and says, don't worry, doctor said it's fever, we're fine, let's just go home. Nobody does that. Okay? Now I would submit to you that autism is really, it's a symptom of something that's very difficult to nail down. That's a whole different set of topics to discuss, but there's oftentimes potentially an underlying condition that needs to be screened for. Let's talk first about early intervention. Okay, so pillar number 1, early intervention. Early intervention, as I've said, is a beautiful, beautiful system in the state of Iowa, funded by taxpayer dollars, where individuals working through these organizations will come into the family home, dive into the narrative context of the family, and provide therapies and services at no cost. At no cost. You would be amazed how many people I see who come to my clinic after 6 months of waiting and say, I'm like, so tell me who's involved on the team, any therapies or services locally? And then there's so many people who say, I don't know, they just told us to wait and see what you thought. And they just see my head drop. It's like, oh, okay, yep, well, good, let's do that, let's take care of that. So in-home therapies and services provided through agreements between organizations and families, such as the IFSP, or the IEP when children get older. These are, as I said, no cost. Anyone can make a referral. It's not like Dr. Noble has to make it. I tell families, I'm like, look, if they're not meeting your needs or they haven't been back in a while, just call them on the phone. They're like, I can do that. I'm like, yeah, you can do that. Just go for it. That's what I would do. And then one of the things I really appreciate about this is that it's based on skills, not necessarily diagnoses. Now, we'll talk in a minute about how there's some strengths to that model, but there's some weaknesses. But in whole, I like that. I'm very much a skill-based person. I don't care as much about your diagnosis. I care about your quality of life. What can you do and what will you do next? Based on skills, not diagnosed. But here's the problem, friends. This is paradox number 1, okay? When we think about the number of children between the ages of 0 and 3, and I apologize, the slides have changed. I always wonder why this happens at conferences. I always get the slides. I'm like, why is the speaker's slide so different? Because they weren't ready like 2 weeks ago. So I apologize. There's 120,000 children on average in the state of Iowa at any one time that are between the ages of 0 and 3. 120,000 children. That's based on birth rates from 2014. What we know from CDC findings in regards to children with special health care needs is roughly 1 out of 6 children are going to have some kind of special health care need. Okay, so it doesn't take a genius to do the math. That's roughly 20,000 kids. 20,000 kids in the state of Iowa, if we're consistent with the rest of the United States, are going to have some type of special health care need. And I acknowledge that varies a little bit. Not all those kids will qualify for services through early intervention, but potentially a lot of them could. What we know from last year's data, as provided from the Department of Education, is that just over 6,100 children were referred from birth to 3. 6,100 children. So, what does that mean? That right now, even though we love this system, and I think it's fantastic, it's fully functional. These folks are overworked and underpaid. They're running. I mean, I was looking at the AEA zones on this map back here. I mean, I was looking. I was like, whoa, these zones are huge. These different AEA regions are just gigantic. These people are driving around in a Chevy Malibu, 80 miles. I mean, a round trip to spend 15 or 20 minutes with 1,000 different kids. Okay, and so it's an overworked system already. And what if I told you it was only at 30% capacity? What if I told you that if we were really going to accurately reflect the data, we would refer 3 times as many people? How would the system work then? Why do I bring this up? When we were advocating for coverage for ABA therapies and services to be provided or covered by private insurers, one of the responses that we got from legislators was this: hey, that's how legislators talk, okay? If there's a legislator, I apologize, maybe you don't look at that, but that's, in my mind, that's how you talk. Hey man, hey, so our request, we got kids that spread all over Iowa, we need access to therapies and services, and they'll say, hey, look, isn't that what the early intervention team can do? Like, don't they have early intervention in Southern Iowa that can reach these needs? And then I think in my mind, I see these numbers and it's like, and I just about have a seizure, like right in the, I'm like, you've got to be kidding me. This is going to explode. This is the housing crash of 2007. Like, this is going to happen. It is going to implode if we actually capture the number of kids that could be captured. And we're relying on an overly taxed, under-resourced system to meet the needs that they're really not as well equipped to meet anyways. Other issues with this is that, from 0 to 3, if for an early intervention model, it's primarily an educational emphasis. So the kids that I see in the clinic that are scariest to me, the kids that terrify me, are not the 6, 7, 9, 12, 15, 18-year-old kids, beautiful, maybe they're struggling with some communication, maybe they got some aggression, maybe they got some insomnia or self-injury. Those kids don't bother me nearly as much as the 12 or 15-month-old with low tone, doesn't turn to voice, and is failing to thrive. Those kids are terrifying, okay? And when I think about 0 to 3 services, an educational emphasis is always important, but truth be told, perhaps a medical aspect of that might be useful. Perhaps in those certain situations, a diagnosis might matter. Even if a child doesn't necessarily qualify for therapies and services at 24 or 26 months with an early intervention evaluation, if they have Down syndrome, if they have an autism spectrum disorder, they may not qualify today, but they will qualify in the future. And if we can get in the middle of a spiral of kind of just maladaptation and these kinds of ways that these kids learn to suck, swallow, the way they learn to walk, the way they learn to control their bodies, if we can get involved early, maybe when they don't qualify for services based on their diagnosis, outcomes could be better. Outcomes could be better. But that's going to take a lot of work. There's limited service frequency. These folks, as I've said, Chevy Malibu driving 100,000 miles around in a circle, right, doing the best they can to get in and out and do the things they can do when families don't want to meet with them, or they're not home, or they don't show up, or they don't want them to be there. And so they're trying the best they can, but it's difficult to get the kind of service provision on a frequency that is going to make the most impact. And we've already talked about the legislative view of early intervention, which is oftentimes the service is viewed as some kind of savior, where they're going to come in and kind of meet the needs of every child in rural Iowa, which we all know isn't true. And then it's not only to mention that, but there's certainly, not to get into this, but there's a big issue with just a lack of developmental screening and practice. Just trying to get pediatricians and family practice doctors to do standardized screening to identify children who have special healthcare needs to begin with. And when they do, don't just refer them to Noble. That's not the answer. That is not how the future is going to look. Well, I don't know, just send them to the center, to the person who does the thing, and that's it. And we'll just move on. That's not how the future can work in Iowa. Okay. Let's talk about pillar number 2. Pillar number 2 is access to private therapies and supports. Okay? So what I mean by that is speech, occupational, physical therapy. I know you know this, but so many families need to be reminded that, look, the early intervention is only one half the coin. You got to flip the coin over, because we have an educational diagnosis, but we also have to have an individual's educational services. We also have medical services. We also have people who are working with these families based on billable services as billed to insurance. Kind of in addition, it's not better or worse than early intervention. It's just different. emphasis is on life skills. It's on not, I want you to sit, I want you to walk, I want you to talk, but I also want you to know how to zip and to brush and to comb and to feed yourself. But again, herein lies a tremendous paradox. If we go back to the numbers and we focus just on speech therapy, because truth be told, I very much value occupational therapists and I very much value physical therapists. But the majority of the majority of the evaluations that I conduct are with the child who doesn't talk. It's not the child who doesn't walk or the child who doesn't have a pincer grasp. It's the child who doesn't talk. So if we just look at it from speech therapy, I think it gives us the best kind of gauge about how possible this is in the state of Iowa. So we know from 2010 census data, if we looked at children from 0 to 18, there's just over 700,000 children in the state of Iowa. And if we do the math again, 1 out of 6, 121,000 of those folks are going to have special health care needs. If we looked at how many speech therapists are licensed in the state of Iowa, I didn't say practicing in the state of Iowa. I said maintain a license in the state of Iowa, which is that information is available from the Department of Public Health. We know that there's just over 1,100 licensed speech therapists in the state of Iowa, licensed speech therapists. I don't know how many of those see kids. I don't know how many of those are even living in the state or even working currently. But what I do know is that would mean if we were going to refer all children, let's say of the 121,000 kids, let's say they required some kind of speech goal and they qualify for therapies and services. That would mean that each speech therapist would have 104 children on their caseload. 104. If you're a speech therapist and you have 104 children on your caseload, you're probably not going to be a speech therapist for very long. Okay? You're going to need a break. So that is a lot. The average speech therapy workload, it varies by institution and it varies by organization, but 40 to 50 is kind of, think about that, it's a really busy speech therapy practice. So in a sense, what we're asking speech therapists to do is to double their workload. So we would have to essentially double the amount of speech therapists in the state to even begin to meet the need of functional communication in children. Not to mention that, the local therapies are hard to find. Local therapies are very difficult to find. If you live in Baxter, there's not a lot of speech therapists looking through the map of Iowa and saying, you know what I want to live? Baxter. Baxter or Nevada, not Nevada, Nevada, or Madrid, not Madrid, okay? That's where I live. I live there, right? And it just doesn't happen. And so it's oftentimes a struggle. I've had kids go to nursing homes to try and talk to the speech therapist at a nursing home to see if they can take a break from the things they're doing to do some functional communication training with a child in nowhere, Iowa. I've had to call these people and beg them. They'll say things like, and I love these people and they're great, but they're not into kids, a lot of these folks. And I have to say things like, look, if you could just do this and this and this, and like, well, but I'm not really comfortable. And then I'm like, well, yeah, I do things I'm not comfortable all the time. I'm not comfortable talking to you right now. But I need you to do this because comfort is not an option that we have. These are desperate times. If you're a speech therapist and I know where you are, I'm probably going to call you at some point in time. And the wait list for speech therapy services, as you all know, are excessive. If you're lucky, if you are blessed, a speech therapy evaluation might happen in a month or two. But an evaluation and a therapy slot are very different things. You may be seen in a month and say, yep, you qualify for therapies. You might not get a therapy slot for 6 months. But 6 months. So yes, early detection is important. Yes, early diagnosis is important. But what do I care most about? I care about early treatment. I care about doing things. Pillar number 3, access to Medicaid. Okay, I'm trying to keep my cool on this one. Okay, now listen, when I say Medicaid, I know we've got a different thing now, and there's all these great organizations that have kind of taken over Medicaid, and so far it's so good. It's been good for me. But what I want you to know is you are a family coming to my clinic. You both work, you have bachelor's degrees, you have student debt, you have 2 kids, you work hard, you come to my clinic, you got a kind of insurance that I can look at very quickly and tell you is going to do nothing to help you. But I have to spin this. Okay, I have to be very careful here. But the message there I have to share with families is say, listen, your primary insurance is not good enough. Like, really, this seems great. And then I say, actually, I don't mean to be rude, but I don't know that I've ever encountered a private insurance of any sort or kind that's good enough, typically, okay? So I tell them, look, we have to find a way to get access to Medicaid insurance as a secondary payer. We have to have it. If not now, we'll need it then. So we have to start now. And I'll tell you, there's actually 5 ways I've learned that in my dealings with my friends, I have these like secret insiders at DHS that I'll call and I'll talk to and I'll tell them. So if you're at DHS, I'm not giving out any names. But these people tell me how it works, okay? And basically what it is I tell families that there's a bunch of different ways to get Medicaid. Maybe it's through a waiver, right? I haven't gotten to the paradox yet. Maybe it's through a waiver. Let's do IQ testing, or let's do the brain injury waiver, or let's do the health and disability waiver. Let's just get on a waiver wait list, and surely that big basket of goodies will come to the house tomorrow with a bunch of delicious treats inside of it. That'll come, right? Maybe it's based on your income, okay? And I do have some families like that, but truth be told, most families that I see don't qualify just straight on income. Maybe it's through income based on the fact that you have a child with special health care needs, which is elevated income requirements. Maybe it's through disability determination, which is also a big issue that's very helpful for families. And not only that, but Medicaid, access to Medicaid will often provide families with expanded coverage for things that they can't currently get covered, not just therapies and services, but sometimes genetic testing and certainly access to ABA. So I have to get these kids Medicaid fast. But the paradox is great in this regard. When you think about waiver wait lists, okay, when I started here in 2012, I likened myself to like finding a back door at like DHS, like that guy who paid to go to the concert and then stuck to the back and let all of his friends in. Like that's exactly what I was doing. Okay? I don't know if DHS is here, but this is what I was doing. So I came in and I propped the back door open for intellectual disability waiver services. I was like, okay, here we go. You're 2. I'm going to send you to a psychologist. It's not going to go well. Okay, not because your child's not smart, not because your child's not smart. It's because the state of Iowa isn't always very smart. Okay, so what we need to do is we need to get a diagnosis of an intellectual disability based on cognitive testing, and then we're going to fill out this waiver paperwork, and I'm going to hold the back door to DHS open, and you're going to sneak in. And then in a couple months, bam, you're going to have an intellectual disability waiver with access to Medicaid. I was doing this like it was going out of style. Like, it was awesome. Truth be told, it was going out of style, turned out. Because I don't know if it wasn't just me. I don't think it was just me, but man, there was a lot of kids on waivers in Polk County. Fast. It was awesome. I was like, yeah, bam. I found a guy who would do it, who would take Medicaid insurance, would see young kids like, bam, let's just do this. But then something happened. And I didn't know about it until it was too late. All of a sudden, a wait list showed up. Now, I was familiar with wait lists, but not wait lists like this. This is the Death Star of wait lists, okay? So what we know now is that certainly the wait list for all waivers is extensive. And I know people come off the waiver and there's big groups and then it kind of opens up slots. I know that. I believe in that. And I believe in the goodness of the organizations that are administering this. I'm a big fan. But truth be told, any wait list is too long, but certainly years, when it's a year's wait list, that is essentially a service that doesn't help my patients at all now. Not at all, okay? But to be fair, it does in the long term. But the next question is, so you live in Ames. You live in Ames, you have Medicaid insurance already. I want to get you access to a waiver. You're 4, you have Medicaid. Who will do your IQ testing? Who will do it? You live in Spencer. You live in Storm Lake. Who will do it? I will tell you, this is a big problem. There are folks that will do it. There are folks that won't do it, and I don't blame them. But it's very difficult to find a licensed psychologist in the state of Iowa who will see kids down to certain ages. But that's necessary according to the DHS code. It has to be a licensed psychologist or, ironically enough, a psychiatrist. And don't think I didn't try to get that changed. Didn't work. But I did. Okay, so IQ testing. And then lastly, income model. Truth be told, most people don't qualify. Okay, pillar 4. I got only good news at the end, people. Only good news at the end. Okay, pillar number 4, ABA, Applied Behavioral Analysis. Now, for those of you, I know most of you are potentially familiar, ABA is a beautiful science. Okay? You take data, you put children through a series of activities or interactions, you gather data about what potentially potentiates behaviors, you put systems in place to try and change those behaviors, and you do it all in the context of data. You devise a treatment plan, and then you kind of work on that as time goes on. It's beautiful, it's crisp, it's clean, it's just amazing. It reduces challenging behaviors. What does that mean? What does that mean? That means that Noble doesn't have to use meds. Now, I'm going to be clear. I don't get to use them unless you give me that permission, because who do I work for? I work for you. But I want to be very clear. My intention in seeing a child is to never put them on a medicine, ever. But how accessible is ABA? What do you do when you've got families that really struggle to just understand the basics of behavior? What do you do when a child with a single mom who keeps getting pulled out of work because Johnny is biting people at daycare and can't make transitions? What do you do? I'm not a fan of it, but I'm not going to lie to you and say that I don't do it a lot. I do. But my hope is that we can change this system. Here's the problem, friends. We also know that in the state of Iowa, there's not many board-certified behavioral analysts. There's not many. Recent data would tell us there's approximately 75, which is probably an overestimate. When you look at the approximately 10,000 children in Iowa, based on the 1 out of 68 statistics from the CDC, we know that individuals who are providing BCBA who are providing ABA would require a caseload that would be in the hundreds. They would have to be actively managing hundreds of patients. If every child in the state of Iowa got access to an ABA provider licensed by the state, then that would require that ABA provider to see hundreds of children on their caseload. But what do we know about what is recommended? What we know is that in order to be effective, 12 to 16 patients, up to 24 depending on if there's help, is what a typical ABA provider is able to supervise effectively. So of all the paradoxes that we've discussed so far, of all the funding that's out there to provide families with access to these brilliant and beautiful services, where are these people going to come from? We can grow a lot of things in the state of Iowa. This is a stretch. This is a stretch, okay? And then lastly, of course, who pays? Now, there's other issues. If you want to grow up and see providers emerge within your city or your state, it is in your best interest to devise training opportunities for these people, because there's so much data that suggests that when people train in a place, they stay in a place. So what we need to see is the emergence of new master's level programs in ABA. Yes, there's money on the table, and yes, those opportunities are existing, and yes, there's brilliant and wonderful people working on this, but I'll tell you, as it stands right now, Briarcliff's got a big job, okay? And we're seeing more and more things coming, and I believe we're going to see more and more things in that regard. But truth be told, we have to have more training opportunities here. Okay, pillar 5. So this is me. This is mine now. This is the medical evaluation, okay? The medical evaluation for children with an autism spectrum disorder is complex. It involves genomic testing, looking for copy number variations, deletions, and duplications of material. It involves single nucleotide polymorphisms, okay? This is not going to be on the test, okay? Which is single gene change. It involves single gene disorders. It involves methylation disorders. It involves metabolic conditions. So anyone who speaks genetics at all, I pretty much just named every genetic mechanism there is. I tell families, listen, if I wanted to work you up in regards to how evidence-based practice would dictate that I do that, and when I put a needle on your child's arm, you can plan, if you're paying out of pocket, to spend $5,000 like that, like in seconds. Bam! That's the most expensive blood you ever see in your life. And these labs go all over the country, and they come back, and you know what the pickup rate on a lot of these evaluation tools, a lot of the best studies, a lot of the most robust genetic testing we can do, 25%. If I was to sequence the genome of every child who comes in with an autism spectrum disorder, the likelihood that I will come up with a diagnosis based on whole genome sequencing is 25%. Some studies will say a little bit higher, but it's already bad. But when you're a geneticist, 1 out of 4 ain't bad. Like, yeah, we'll take that, we'll roll that, play that game. But you never bet money on it at the dog track, ever. So, what I want you to understand is when people engage in these kinds of evaluations, I want to submit to you that there's a limited number of people who are truly qualified to do this. A limited number of people within the pediatric realm who are truly, I feel, equipped to walk into a room and know kind of from a medical standpoint what needs to happen next. Developmental pediatrics is the field that I represent. Clinical genetics. Now, they might not be too skilled on deciding if it's autism or not, but they know what to do. They know how to spend a lot of money. They know how to do that. Child neurology. And we also have child psychiatry. And certainly there's psychologists that are wonderful at the descriptive diagnosis. Way better than any of us are ever going to be. But remember what this is. This is a pillar of medical evaluation. Okay? This is making sure the child doesn't have neurofibromatosis or 17q12 deletion syndrome with polycystic kidneys and aortic root dilatation. This is necessary. Okay? So people like me are needed, but there's a big problem with this, and that is there's a remarkably limited number of providers to do this in the state. Just a quick word on evaluation. For those of you who've never been seen in a clinic, you don't have a child with special health care needs, or you don't necessarily know what patients or families that you're involved with are going through, here's just a real brief introduction to what we do. So families come to the clinic, and during a 2-hour session with me, maybe 90 minutes, kind of depends, I will do an interview with you. And what my goal is to understand you. Okay? People ask me, why did you go into developmental pediatrics? And I say, listen, because I value the narrative context of people. I care about where you live. I want to know how your marriage is. I want to know how many cars you drive. I want to know what your relationship is with your mother-in-law, which is not good, usually. Because if I'm going to help you, I have to understand where you're coming from. If we're going to change the state of Iowa, in order to change the system, you have to understand it. That's my intent is right now. Is I want us to understand the pitfalls of what we're dealing with. We do interviews. We do observations. It's not just DSM-5 criteria. Listen to me. I'm not just circling, I'm not doing that in my clinic. I'm watching because you've all worked with families. We've all worked with families who have tried to lead you down the wrong path, right? Tell me about, is it easy to make him laugh? Oh yeah, no, well he laughs all day. He's hilarious. Does he turn to your voice? Oh, tons. He turns all the time. And then oftentimes during the course of an interview or observations, I realize that this isn't real. It might be how you perceive it, but it's not going to be how I perceive it. So we do things. We do testing. We do things like the ADOS. We do things like the social communication questionnaire. We do all these kinds of different strategies. Sometimes we'll do receptive and expressive scores. We'll have speech therapists that see kids with us. We'll do these things, and sometimes we're moving towards adding a psychological assessment to our evaluations because I want so desperately to give people the right information. I want them to have the right information. And the truth be told, these evaluations could be much more extensive. I could add all kinds of people onto this team. But my question to you is, does it need to be more? Do you need to have more of a medical evaluation than this? And I would say at this point in time, given the situation we're in, no. So our goals of the evaluation are very simple. I want to understand the best of my abilities, the descriptive diagnosis that best characterizes your child. I've already told you your child's awesome, right? But I told you that's not billable. So I have to default to other things. And there's usually a list of things that are going on. Autism spectrum disorder is usually one consideration that's going through our mind, but there's other things. Do you have a receptive and expressive language today, possibly related to an intellectual disability? Do you have sensory issues? Do you have feeding difficulties? Do you have sleep problems? Do you have aggression? Do you have impulsivity? Do you have transition struggles? Do you have self-injury? Do you have constipation? These are things that we've got to know because, again, if you just look at it from a sticky note perspective, if you don't know what underlies some of those behaviors, you're really going to struggle to help these families long term. Imaging, blood work, genetic testing, coordination, collaboration, and coaching. Like that's me in a nutshell. And that's the kind of things that we do when Pillar 5 is functioning well, but it's not. It's not. Listen to me. 58 providers in the state. I would submit to you, 58 providers, we'll say 60. Feeling generous, Iowa. 60 providers in the state of Iowa who on any given day, I would suggest, have a background that would equip them to know how to best approach a child with special health care needs on an evaluation basis. Neurologists, developmental pediatricians, geneticists, and psychiatrists. You kind of see the breakdown there. And what that essentially means is that we were all going to share the burden of evaluation and management. Each of us would have to take about 2,000 kids onto our caseload. 2,000 kids, that some of which will need nothing, others of which will call your office every day. Every day. They will call, and I love them. I don't always know what to do, but the truth is, there's just families that have different needs at different times. Early evaluation is key, but how long do you think it takes to get into people like me? Early evaluation, early detection, early diagnosis, 9 months, 6 months, 12 months. Genetic testing, and when they see us, oftentimes what we want to do isn't fully covered. So, as we move towards the close of our time together, I think this is an opportunity for us to kind of talk a little bit about what this means. Because we talked about what's necessary. And you folks are smart people. You knew this before you came. okay? And you knew that the problems within those needs were great, and I hope, if anything, I've quantified just how great they are, because our options right now is not status quo. I often walk into the workroom in our offices, and there'll be like people there working, doing things, and there's like, there'll be students or whatever. And I come in just looking disgruntled and homeless. It's kind of like high roll. And I come in, I go, hey, what's your name? And they'll be sitting there like, oh, my name's Becky, I want to be a doctor, I just want to be a doctor. And I'll say, Becky! They say, yeah, I'm turning 40, things are getting dicey for me. So I walk in, I'm like, Becky, hey, listen to me. What is your big problem today? What's your problem? I don't know. It's like, am I sitting in the wrong spot? No, Becky, you're not sitting in the wrong spot. What I want to submit to you as we talk about the way forward in the state of Iowa is what we need most is people with problems. We need a group of people who have tremendously huge problems. You know what my problem is? Do you all know what my problem is? My problem is that I've got kids scattered around the state of Iowa that I'm not convinced I can put the necessary therapies and services in place to ensure the relentless pursuit of their potential. You know what my problem is? It's the potential of these kids. I want it more than anything. I want to know at the end of the day that when I hang out my shingle and I'm done in central Iowa, kids in Leon, kids in Baxter, kids in Council Bluffs breathe easier because of the work that we did here. Not because they saw me, but because something was changed, something was unleashed, something was cut off or broken loose. People were empowered to change things in their communities. My problem is the potential of children. My problem is your potential. It's you. You're my problem. You're a big, beautiful problem. Because some of you are like so many people I see, where you go to work and you forget why you came. Think back when you wrote that ridiculous essay about why you wanted to go into social work. Remember? Or that medical school essay that was just blah, 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 and I'm going to Nobel Peace Prize and blah, blah, blah. Remember that? Do you remember what you thought you would be when you were in college? How many of you set out to do what you're doing and did it? So many people in medical school, so many people in residency, so many people in hospitals walk around like these empty zombies. Like they're just shells of people. Like you go up and you just kind of knock on them just to see if you hear an echo. And I have to remind residents, I say, listen, I know you're miserable, but raise your hand if you're living your dream. Raise your hand if you're living your dream. Because it doesn't mean the dream was bad. It means that something changed. And what I want to conclude our time with today is that it doesn't have to be like that. But not if we leave things the way they are. So the lady here, I'm like, you know what? You got to have a problem. We got to have problems. What are you trying to address? What are you contending for? What are you contending for breakthrough for in your life, in your work, in your community? I want to end with a brief analogy. So in the early 2000s, a Finnish American man named Torvalds Linux developed a type of computer code that was meant to directly compete with Microsoft Office. But the way he went about it was very different. He posted on an internet blog site. He basically said, here's some code I'm working on. Take a look. Tell me what you think. Let's work together to make this better. So what do you think happened? Over the next several years, this code became developed by people from all over the world, and it cost nothing. It was given away. This guy developed a core, and he gave the rest away. There was these 5 things. There's these things in the middle that he couldn't change. But everything else was up in the air. And over time, through a crowdsourcing movement, everything started to change. And this is now where we get the Android phone. This is where we get Chrome, the Chrome operating system. This is where we get all these things from some crazy guy who decided that maybe I can't figure this out on my own. But if I work together with people and understand what you want and understand what I want, maybe things can be different. What I want to submit to you is that the answers to our biggest problems are in this room. The answers to our problems are in this room. Some of you are burnt out, you're sick and tired, and believe me, I have been where you are. I mean, I remember when I was 34, and this is going to use some of you are like 34, but okay, I was 34, and I had a bunch of kids, and I achieved all my goals. I achieved every goal I set out to. Now, that doesn't make me special, it just makes me dumb. So I had all these goals, and I achieved them, and I remember sitting at my desk in my office in the developmental center at Blank, and I remember just crying, just sobbing. I mean, if you come into my office now, you won't see any diplomas on the walls because I didn't want to look at them. You won't see the board certifications. They're all in the back collecting dust. Because truth be told, I didn't walk this far to just have something that hangs on a wall that makes you impressed, which you don't even care about anyways. So many of you are in that position where you need to know the difference. And this is free for you now. This is off the cuff, but I want you to understand this. I want you to understand the difference between breaking down and breaking through. Listen to me. If you are breaking down or breaking through, I'll tell you what, it feels the same. It feels absolutely the same. You look at your caseload, you look at what's going on in your marriage and your family, you look at what needs to happen in your school or your district or your therapy group, and you feel like you're breaking down. But I will tell you, the difference between breaking down and breaking through as it relates to life and as it relates to the things that need to happen in this state is if you can answer the question, what am I contending for? If you feel like you're breaking down, but you can answer that question, I want to encourage you, you are not breaking down. You are about ready to break through. So keep at it. Be the squeaky wheel. Be annoying. And remember that not all of your friends are living their dreams. Some of them are hating their lives. And you're like, well, I hate my life. Well, listen, no, you don't. This is a pep talk now. You don't. Okay? We can get this back. But what I want to submit to you is in our time as we close, we're going to land this plane. I want you to understand that if we work together to collectively solve these problems, what do we need more? We need more providers in the state. We need more ABA providers. We need more master's level programs. We need early intervention to be more medical in their diagnosis. We need these things to be in place. Listen, I can't solve those problems. I don't know what to do. But you do. You do. And we have to start figuring out how to work together. But it will get messy unless we have a kernel, right? This is why the Linux operating system still works. This is why it works. Because everybody changes everything. But the guy who invented it had 5 things you could not change. I want to submit to you, Iowa, in love, these are the 5 things that could potentially guide us to the future. Number 1, whatever we do, wherever you go, whatever you change, whatever you build, whatever you create in your community, it needs to be absolutely soaked in accessibility. The time of asking the family to go to the center to see the specialist who has the wait list and has the nurse and then goes into the thing. We are done. It is over. Okay? I feel like I'm predicting the housing crash. Like, it is over. You have to trust me. It's not going to work anymore. We've got too many kids. We've got too long a wait list, and we're overly emphasizing the wrong part of the system. It's not assessment. It's not diagnosis. It's treatment. Accessibility. Can the farthest, poorest, most uneducated patient on your caseload access this service? If not, change the service. Number 2, value. Listen to me. The time of us having people come and giving them 3-ring binders full of junk and telling them about their disorder and telling them what they need to do 4 hours away to kind of figure things out is over as well. We absolutely have to take time and step into the boat of the family and provide value with every visit. What does this family need? They may not want ABA. They may not want it. They both work. They live 2 hours from the nearest ABA provider. They're not interested in it. They don't want it. Okay? So, you know what else they don't want? They don't want the diagnosis of autism. They don't care. So mixed receptive expressive, pragmatic semantic, whatever, doesn't matter. They don't want it, right? So then you come back to your school or your organization, you're going to say, what? This kid's clearly autistic. You'll be like, this is a problem, this is a problem. Listen to me. It's about value. What does that family value most? If you want to change their lives for the good, put away what you think they need and listen to what they need. Efficiency. Hey, I lose money just by turning the lights on. I tell families all the time, you think this center exists because we make a ton of money? You know, surgically excising guilt. You think that pays well? It doesn't. I'm a reckless loser of money on every day. And so, but that doesn't mean that I can't present to you the most clean and efficient process. I'm not about products. Where we go forward from here is not about products, it's about process. Can you see more kids, but can you see them shorter, but in more frequency? Can you see kids for 6 months and then discharge them with a ton of supports in place and then see them back in a year for another 2-month burst of therapy? Can you do that? Can you do group therapy? Can you do telehealth? Can you learn how to do these things or teach families to do them on their own? Efficiency. Could we, in the arena of special healthcare needs, could we come as a black horse out of nowhere with the most beautiful and crisp, value-based, efficiency-based, innovative system in the world? Yes. Because nobody else is interested in it. But we can do that. Innovation. Continually stimulating progress. The hope that some of these kids have could potentially be based on technologies, interventions, ideas, strategies that you have not created yet. But I will tell you, you are the ones to do it. So start asking those big questions and give yourself permission to just come up with big ideas. Find people in your life who can do that with you. And lastly, empowerment. We have to come to a place where we're into building more than just buildings. We have to find a place where we can take the super smart Sudanese refugee mom and equip her to know how to provide simple ABA strategies to her child because they live so far away. Or speech therapy, or functional communication, or picture exchange communication schedules. Like, are these strategies teachable? And I would say, yes, they are, but we have to empower families. Less noble, more you, family. The relentless pursuit of every child's potential is the goal. Let me close with this. So, at the end of most evaluations, people will ask the impossible question. They always do. They ask it to you when you come to their house. The question you hope and pray they don't ask you. They'll say to me, Dr. Noble, will my child talk? Will my child walk? Will my child live independently? Will my child be happy? Will my child be kind? Will my child have a job? I'm going to tell you the same thing I tell them. Imagine that we go to a nursery, because we're not the kind that has babies, not going to have babies, the kind that has plants. And we go there, and there's a dollar bin, and there's a bunch of super cheap bulbs, and we take a bunch of them, and we go to your house, family, because we're best friends now. And I go to your house with you, and we plant those bulbs in the ground, and we do everything we possibly can to make them grow. Okay? We do all the pillars of care. We're doing the best that we can. We've excised guilt. We believe in our future. We're empowering ourselves to provide what we can in the moment to our child right now in Leon. Dr. Noble, we've done everything. We have watered it, right, sunlight, everything. Dr. Noble, you're going to watch that, and up out of the ground is going to be the first shoot. You're going to turn to me and you're going to say, Dr. Noble, what color do you think the flowers will be? Is it red or yellow or blue or green? And I will turn to you and I will say the same thing I say to these families and the same thing I say to you. Listen, I don't know what's coming up out of the ground. I don't know. It's red, blue, yellow, green. I don't know. I'm not exactly sure if your child's going to walk or talk. I believe they are. That's the future I choose for them. But I don't know. But one thing I can tell you with certainty. I can tell you with absolute certainty. Whatever comes out of that ground is going to be beautiful. Whatever you choose to do in your communities, no matter how meaningless it sounds, no matter how simplistic it feels, I want you to know that the time to do that thing is now. And whatever you do, the fruit from that, I promise you, will be beautiful. I feel like I should pray, but I won't. Okay. With that, I'll stop for, I guess, questions. If you have questions. I'll be around too for the day, so yeah. Should I stay and ask them? Is that okay? Yeah. Any questions? Any thoughts? Anything you hate? Let's start with that. I'm used to that. It's fine. Oh yeah, here maybe you could. Yeah.
Anybody have a question?
I'm Nancy Boswell. I work for Greenfields Ankeny.
Okay.
I'm one of those early access SLPs
Yep.
that drive the 100,000
Yep. In Malibu, did you drive in Malibu?
And,
Yep. Good.
and in Leon and all those.
Yeah. Okay. Good. I had some real friends in Leon. Yeah. I'm big down there. I'm real big down there.
Anyway,
Yeah.
and but one thing, it's really not a question, but one thing I do want to comment on is that when we have parents that have gone to you, they come back more empowered.
Good.
And they feel better about whatever the future looks like.
Good.
And so I want you to know we really appreciate that.
Good. Thank you.
And I know I have more families that are headed to direction, and that's with early access. We're trying to give parents more empowered and to help them learn what they should be
Great. Thank you.
We have said we would, like the clone and have more.
Sure.
But I don't think that's going to happen.
Yeah.
So, we need to clone more
Yeah.
providers, I think.
Yeah, I think they're coming. Thank you, Ben. Thank you for the work that you do. Thank you. That's good.
Could you tell us more about how you get kids on Medicaid?
Sure, I will, absolutely. So here's what I'm doing right now, okay? Now, I tell families, listen, there's 2 ways to play golf. I'm not a golfer at all. I've got 4 kids. I mean, my hobby is going to the bathroom. So I'm not shooting the links with my buddies, okay? There's a short game and a long game. The short game is going to be access to Medicaid insurance through federal determination of disability, okay? Now there's a trick here though. You have to listen, because people go to the Social Security office and they'll apply for Social Security, which they're going to have to do, and guess what? They're going to be denied. And then they're going to walk away saying, well, I didn't get SSI, so I don't get SSI, I don't get Medicaid, so I guess that's the end of the story. It's not the end of the story. If you get approved for SSI, okay, that's one way to get access to Medicaid, okay? But again, a lot of my families aren't going to do that. They're not going to qualify. But if the federal government deems them disabled, which is SSI aside, then they're still able to access Medicaid. I recently had a family who took my advice in January. I saw them back like 2 days ago, last week, and the child was on Medicaid, and I about fell out of my chair. It's like, what? This works? Turns out my DHS contacts are legit. So SSI will get you Medicaid. Most people won't qualify. Disability determination will get you Medicaid, okay? Which again, it depends, but you send it to the disability office. Next is just straight income, which you know. Next is waivers, which you also know, but that's the long game, right? Because what do waivers do? They do more than just Medicaid. There's a lot that comes in that Easter basket. There's supported community living, and there's respite care, there's all these great things, but it's Medicaid that won't come for 2 years. And you need an IQ test to do it, which is a whole other dicey thing. So I'll usually do the disability, have them do that first, and then I'll also have them fill out waiver paperwork and we'll do IQ testing, because it's just as fast as any other waiver, typically. And then the last one is Medicaid access for children who have special health care needs. So that is an income model, but it's raised, it's way higher, okay? I'll quote that, way higher, but it's higher, okay? So it's not the straight income model. So there's literally 5 different ways that you can spin this to help your families get access to Medicaid. The best option is you'll have something within 4 to 6 months. Most people are going to wait years. Yeah. I had a family the other day, the mom was like, I'm just going to divorce my husband. She was like, I'm just going to divorce my husband and that's it. I'm just going to be single and then that'll drop the income and we'll get Medicaid. I was like, no, let's not do that. No, I'm for Medicaid, but I'm more for marriage than Medicaid, so let's just not do that. Good idea though. People are desperate, and I don't think people understand that. Because if you don't have Medicaid, what are you going to get? Who's going to pay for ABA? Real tough. Who's going to pay the secondary copay for speech therapy? You're paying out of pocket $75, $100 per session, $200 to $300 for evaluations. I mean, it's a disaster. Great question. And we can talk more. Got some in the back.
My question is, why should we have to have Medicaid to get services?
Right. That's a great question, and that's a great question that families ask all the time. Why should I do that? And I say, well, there's a few people you can ask. I would start with your employer and understand why they think on their planet 25 speech therapy sessions a year is all that's needed, right? That's half. That's like once every other week. There's also employers that, they'll pay families will say, no, we've got insurance coverage, no, but we're only paying like $40 or $50 per session. And I'm like, but if you were paying out of pocket, it'd be like 75. Like, So I would say, I'd say there's a lot of legislative efforts in regards to private insurers and asking them to do more of what's necessary to help these kids. The tide is turning. In our lifetime, we will see private insurers pay for ABA therapy in this state. I have no doubt. And they know the clock's ticking. So that's a great question, and I wish I had a better answer. Over here. Don't give that guy a microphone. Nobody with the bow tie. Nope. Nope. I'm joking you. I know this guy. I love this guy.
I'm just happy to see you.
Yeah. Yeah. Took a shower, the whole thing.
With the spread throughout the state of Iowa, clearly there are spots in the state that are pocketed for increased services, right? So Iowa City, Des Moines,
right.
not Sioux City.
Yep.
How do we coordinate care better? How do we do a better job in the state of coordinating care, particularly when we're talking about the medical side of things? You've got an ADA provider who doesn't also provide speech and OT. You've got a speech and OT who doesn't provide ADA. You have a licensed psychologist at another site. Forget about trying to see a pediatrician or somebody else. How do we do a better job of coordinating care?
Yep, that's a great question. And I would say, certainly when we came to Des Moines, one of our biggest goals was to build a connection or a relationship with providers. So one of my first moves was to start meeting with people, either through Des Moines Public or through the Heartland AEA. Because I wanted to present myself as somebody who's not just kind of bequeathing recommendations and like, well, tell the AEA you need a pony and you have to ride around a circle every day and put that in your IEP. Noble said so. Like that doesn't work, right? It doesn't honor these people. It doesn't honor you. My intent is to honor. So I think to begin, in order to coordinate and collaborate care among organizations and providers, the first thing it takes is a level of understanding. I have to know what speech therapists need. I can't send a kid for speech therapy with a diagnosis of speech delay. Like that's not going to work. It has to be something they have to be like, give me something a little bit more, Noble, because insurance won't pay for it, right? So I think first is a level of understanding, but I also think there's a desire to honor. So when I work with schools or when I am able to talk to the AEAs of Des Moines Public, my intent is to honor them and to make sure that they know that I value what they do, and sometimes more so than it seems like they do. Like they don't because they don't get to hear the stories. So, I guess that's not answering a question, but that's certainly where the story starts. Certainly the future is going to be where we are able to more communicate. I would love to have more communication with schools. I would love to know that Johnny goes nuts at 11 o'clock every day with this teacher, and what do you think about that? I'd love to know that data, but truth be told, Sean, I don't hear it. I don't think about it. Because there's 50 releases of information that they have to sign, and they fax the wrong address, and then, you know what I mean? So it's a disaster in that sense. But truth be told, the way we're going to work together is we have to learn to talk. We have to learn to talk each other's language. Because that's like even you and me, like psychologists, man, we could go at it. You're going to say ABA, I'm going to say Risperdal. I was just joking. He's a psychologist. I'm a medic, So there's all these different things. But I think the future is bright, but we have to find ways to work together under a banner of things that we can collectively agree on, which is those 5 things I listed at the end. Like, if we can find a way to agree on those things and not on market share and not on who gets this from Department of Ed and who gets this from Department of Public Health and who gets this from grant, we have to find a way to put down our swords. And if you succeed, Sean, in Sioux City, I succeed. If the AEA people are happy and meeting their goals and objectives, if Des Moines Public is successful, I'm successful. And until we can see it that way, we're all still siloed, and nothing's going to change. So I think things like this, dialogues, interdisciplinary dialogues, and a lot of hugs, Sean. A lot of hugs. Man. That's a great question. Anybody else?
Like your advice on, a lot of families that receive ongoing services through Homestead.
Sure.
And I work a lot with a lot of families that are transitioning into kindergarten.
Yep.
And
right.
often we are seeing that parents, I think it's twofold, they're recognizing the level of service that Homestead provides.
Yep.
But also because they've been on that list so long.
Right.
They're finally getting that daily care.
Yep.
What advice would you give to us as that go-between on deciding, do I have my child miss 4 hours a day?
Right.
Full day kindergarten program?
Right.
What's your recommendations or advice in that area?
Yeah, I wish you would have asked me a hard question. This cake is on. That's a great question. People ask it all the time. They do. And it's difficult because I'm tied between who I want to honor. Because I honor schools and I love schools. I love the fact that schools typically are going to say, no, we're not going to repeat a grade, we're going to go on. I love the deep end of the pool. I love the response to intervention. I love that you don't need a diagnosis to do what you do. I love it. Huge fan of it. We have a lot more in common than we do apart. But you articulate it so well. So your child is 2.5, you're seen by me, they get access to Medicaid, they're on the homestead wait list. It's 9 months, 12 months, 15 months, 2 years, something like that. They get a slot and oh man, now it's time to go to, Schuler. And it's tough. So most families, as you know, are probably going to try and go for the half-day model, which, and to be fair, I think it's within schools' rights to push back there and understand. Like it's within schools' rights. Truth be told, when it comes to ABA therapy, if a child has a level of behavioral struggle that is so significant that it's difficult for them to be successful in school or in home, those are the kids it's much easier for me to say, hey, look, there's a difference. I want you to be successful. I want you to be successful. That's how I decide about medicines. That's what it's about everything. Are you successful in the areas of life that you value most? If ABA is gonna help that child be more successful in a school environment, I think everybody wins. But you ask a difficult question to answer. How long does that go on? Does it just forever? And oh, it's so noble. Just put them in the evening slot at Homestead. Okay, yeah, sure. Them and 10,000 other people are on that wait list. So to be fair, my prediction of the future is that the way we provide ABA in the state is going to dramatically change. It's going to dramatically change. There are going to be choices, options, and there already are, and I want to honor those organizations. I love them. I'm all for them. But think about models where parents get to choose. Think about a model where there's several ABA providers, all can effectively bill an MCO, or all can effectively bill your private insurance, and they can come to your house, or they can do telehealth. These are the things that I, right now, am very much working on, so that we can get these kids to school, and maybe they don't need 2.5 hours a day, 5 days a week. Maybe they need 45 minutes every other week to telehealth, just kind of dusting things off. So right now it's kind of a one-size-fits-all when they're young, but my prediction is that conundrum will improve with time, because I think there'll be more ways to provide ABA than what we have now. So yes, I agree with you, and not yet. Yeah, great question. Thank you.